We're going to move next into some of the rapid fire presentations. The first one is from Joshua Geiger and his colleagues at the University of Rochester. Surgeon volume and established hospital peri-operative mortality rate together predict superior outcomes after open AAA repair. Go ahead, Dr. Geiger.
My name is Josh Geiger, and I'm a fourth-year medical student at the University of Rochester. I would like to thank the panel for allowing me to present our work entitled Surgeon Volume and Established Hospital Perioperative Mortality Rate Together Predicts Superior Outcomes After Open AAA Repair. We have no disclosures. The advent of endovascular techniques has resulted in the conversion of many prior open cases to endovascular cases. Because of this, many surgeons and centers who were once completing many open cases each year are performing significantly less with more difficult anatomy. In the field of elective open AAA repair, a provider yearly average volume cutoff of 7 open aortic procedures of any type has been suggested. Additionally, in 2013, the SVS recommended open AAA repairs take place at centers with an annual volume of at least 10 open aortic procedures of any type and an established perioperative mortality rate of less than or equal to 5%. There currently is a debate regarding whether hospital volume or surgeon volume contributes more to outcomes. With these three pieces of information, we hypothesize that using current evidence and recommendations, surgeon volume contributes more to outcomes than hospital volume. To conduct this analysis, we use the SPARCS database, an all-payer database of discharge information across New York State. We identified 7,594 cases between 2003 and 2014. Primary outcome was 1-year mortality, and we used a generalized mixed Cox proportion hazard analysis, which included common vascular comorbidities. Displayed here are some basic characteristics of the dataset. By the end of the study in 2014, the number of operations, surgeons, and hospitals had significantly decreased. The mean patient age decreased, and the mean Charleston Comorbidity Index increased. Here we see a forest plot showing the results of the association between 1-year mortality hazard ratio and the 3 variables that have been previously recommended. In our dataset, when all 3 variables are considered, along with vascular comorbidities, hospital volume of greater than 10 is not a significant contributor to 1-year mortality, with a p-value of 0.3. However, surgeon volume with a hazard ratio of 0.8 and documented perioperative mortality rate with a hazard ratio of 0.72 are significant. Since surgeon volume and established perioperative mortality rate were significant, we looked at survival curves comparing the combinations of these 2 variables. The green line here represents cases that were performed by surgeons with a volume greater than or equal to 7 at centers with a prior 3-year hospital mortality rate of less than or equal to 5%. This group showed a 1-year survival rate of 91.56, which was significantly different from the survival curves of the other 3 combinations of surgeon volume and established perioperative mortality rate. In conclusion, this work provides evidence that the improved outcomes of high-volume centers, namely greater than or equal to 10 open aortic cases per year, are likely the result of high-volume surgeons operating at these centers. Survival of patients is significantly improved when elective open AAA repairs are performed by surgeons with an annual volume greater than or equal to 7 at centers with an established perioperative mortality rate of less than or equal to 5%. These results suggest more emphasis should be placed on surgeon volume over center volume moving forward. I would like to thank Dr. Adam Doyle, Dr. Michael Stoner, and Dr. Fergal Fleming for their support on this project. I'd also like to thank VESS for this opportunity.
Thanks, Joshua, for that wonderful presentation. I had a question for you related to, kind of the final thought that surgeon volume trumps hospital volume. I might argue in 2021, many of these at many of the centers we all work in are probably done by teams, if you will, meaning perhaps more than one surgeon participates in these operations. And I wonder if from the data set you have, whether that can be teased out. And the reason why I bring that up is many of our young faculty colleagues, in order to get to 7 individual cases per year is probably a large ask. And many of us that bring on junior faculty will share cases to both increase sort of experience, but also from a local quality control standpoint.
Yeah, I 100% agree. That's a really good question. I think, whenever you're making recommendations, especially on a volume standpoint, there needs to be a mechanism in which to provide people to come into that cutoff, right? So you need, like you're talking about, lower junior faculty, they have to have a way to get that volume. And so I think that's like you were saying, a lot of procedures are done that way. We didn't specifically look at it. In the Sparks data set, there are columns for multiple providers. So it's definitely something we can go back and look at in the future. Yeah. And I think that's a really great point.
Great. Much in the theme that Sunday of this meeting was always an NFL day, and that my youngest one is a huge Josh Allen fan. I appreciate the Bills logo.
Yeah, go Bills.
Chris Smolak asks, in this data set, is 30-day mortality collected? And then were you able to distinguish where the clamp site was and how that affected outcomes?
Yeah, so the 30-day mortality rate that we used was established prior to the day of the procedure. So we collected that based on procedures that were done at centers and by surgeons 3 years before that specific operation was done. So that's how we collected that. As far as clamp site, no, we don't know exactly where the clamp site was done. And so that's kind of a limitation here. We did have multiple different procedures that were included in the volume. So it's all open aortic procedures is what we tried to collect. However, from like an open aortic aneurysm perspective, we don't really know where that clamp site was. And there's really no way in our data set to get that information.
We also heard during this meeting about explants, from a low frequency disease consortium group. In this data set, can you distinguish just elective first time open AAA versus some convoluted, either infected, prior endograft, endoleak, et cetera, and are those outcomes different?
Yeah, there is a way to do that. We can go back and look at patients that had EVARs prior. We didn't look at that yet. It's something that I think is a good point. And to see if maybe the outcomes are, like you said, different, because I could imagine having an implanted graft would change your outcomes for sure.
Okay. Max Wohlhauer is also appreciating that you're not wearing a tie and representing today. Jason Kim asks whether from the data set, length of the operation or even things like blood loss, could you have just used that as a surrogate for outcomes, and perhaps do less experienced people have longer procedures or more blood loss, and maybe that's more the tie to the overall to mortality?
Yeah, I think ultimately that's what we're trying to get at is and kind of one of the foundational hypothesis of our work is our higher volume surgeons better able to kind of perceive complications coming or take actions earlier, and that leads to the better outcomes. As far as time, there's no, to my knowledge, there's no column or data within the Sparks data set that correlates to the time of the procedure. However, we did look at like post-operative hemorrhage and stuff like that. And they weren't any different from a center volume standpoint. However, there was a lower rate of hemorrhage from a surgeon provider volume standpoint. So that there's definitely merit to that hypothesis.
Great. Okay, wonderful job answering the questions too. Appreciate that.